Say that it is a very pious day today, and we welcome our new addition to the faculty. Guest of the day, or rather he is now one of us, shortly he will be one of us, Professor Robert Horowitz. We need to collaborate with the best in the world. In this context, taking a step ahead in that direction, we are inducting Professor Robert Horowitz into the Faculty of Dental Sciences today as an adjunct professor. Dr. Robert Horowitz graduated from Columbia University School of Dental and Oral Surgery and is a very, very senior and well-renowned personality in the field of implantology and piezosurgery.
It's a great honor for SGD University that we have Professor Horowitz today with us. The students, the faculty, the interns, the postgraduates are going to get the maximum benefits because the latest research in America, in the world which is going on and what is being practiced will going to be disseminated directly to you by none other than the professor himself.
I extend my heartfelt thanks to Dr. Robert Horowitz and welcome him to our faculty. It is due to relentless effort of our own Dr. H.S. Grover, Head of the Department of Periodontology. Thank you, sir, for your efforts.
First of all, philosophy. Very simple. We all got here based on our hard work and our understanding of science, our reading of the literature, and our putting that together to make our own philosophies of patient care and of education. Because at heart, think about what we are. Yes, we are doctors. And as doctors, we are entrusted with the health of our patients. If we mistreat them, they may lose a tooth, they may lose a bridge, they may lose the ability to go out in public. They may lose self-confidence. They may lose proper nutrition. We, as oral health care providers, are responsible for a lot of their life. We are also teachers. My mother was a second grade teacher. My father, who was a dentist, never taught except life lessons. And he gave us a lot of life lessons. My sister is a full professor in a medical school. We believe very strongly, not that we're better, but we have more knowledge and more experience and different ways to look at things. The more ways you look at a problem without someone telling you the answer, the better you will be able to handle all of the different challenges that face you in your life as humans, in your career as doctors, and maybe one day up on the dais. So, as a student, what is your job? Your job is not just to get the best marks and be the top of your batch. Your job is to learn from your books, from videos, from instructors, from guest lecturers, from your patients. How to speak to patients, how to understand not where they have a cavity or where they have a loose tooth or where they need a replacement bridge. But it's how to understand the patient behind it so you can treat them as a whole, not just as a filling on 3/6. But as a doctor, we need to understand everything about them. Also, those of us up here, we are still all students. I don't sleep a lot. I read literature every day. I work on the papers I'm writing every day. Because I believe that I still have a lot to contribute. That there are holes in the literature that I want to fill in about certain types of research. And I want to work with you guys and ladies on research projects to help with that. What are the differences between you and us? We have the knowledge, the science background. We know how to read literature. The more articles you read, the more books you read, the more you will understand how to glean the jewels out of it. And not just look and figure out what you need to study for the exam. Patients are different. My patients in the US, I guarantee you, some of them have paid for one set of dental care throughout their treatment with me more money than some of the patients you treat will ever see in their whole lives. Why does that happen? They have access to the money, but more importantly, they understood the value of the treatment I delivered to them. I spend more time in every surgery explaining the procedures that I've already explained. I spend more time in my consults explaining our philosophy of care than just, you have a cavity, you need root planing, you need an implant. Because once you make that personal connection, everything goes more smoothly. This is the most important thing. I've worked in India on judges, on ministers, on family members of parliament. I've worked on assistants and lab technicians, and I've worked on street sweepers. Everyone that I have done surgery on in India, I have thanked afterwards for giving me the honor of treating them. Patients don't take what we do lightly. Some of them are scared to death of the simplest procedures. I had patients in an office I worked in that needed general anesthesia for prophylaxis. And I have other patients that I've done a full arch of extractions, implants, and immediate restoration with local anesthetic. They are all different. It's our job to figure out the similarities and differences. Every time a tooth is extracted, you lose bone, height, width, and you lose keratinized tissue. So whether your patient is going to end up with a removable prosthesis, a fixed prosthesis, or an implant-supported prosthesis, if that volume of bone is not preserved, your patient will end up with an inferior restoration. Inferior in the ability to be retained, if it's a removable. Inferior in the ability to withstand the forces of plaque and inflammation, if it's fixed. And the inability to get an aesthetic implant-supported restoration, if the crown is in the wrong place and in the wrong shape. So the problem we have with grafting is there's so many materials on the market. I am out there on the bleeding edge when it comes to grafting. Anything that comes out, I try. There are things that I try years before other people do. But what does that mean? I have to understand the biology of how the materials interact with the body to see if I'm willing to try them in my patients. If the biology makes sense, if the research that's out there makes sense, I try them. With all the materials I've used, all approved by the US Federal Drug Administration, I've taken 5 graft materials off the market. Because even though they worked in animals, in long bones, they did not work appropriately in humans. So we need to understand the biology of how these graft materials interact with human bone. I'll give you for instance. Did any of you ever You've all had popcorn, right? So did any of you ever get the little husk of popcorn stuck under your gum? Does your gum like it? Does your gum get irritated? And unless you get it out quickly, you have the beginning of periodontal inflammation. You have pocketing, you have bleeding. Take that one step further. When I was in my residency program, my professor wanted to make infrabony defects in dogs. So we took, do you guys have the stainless steel composite polishing strips, the one with the holes in it like sandpaper? So we would take the dog into the operating room and with a burr remove 10 millimeters of bone, a millimeter thick. And we would place the stainless steel strip perforated between the bone and the tooth and suture it into place. What do you think would happen to any of you if we did that around one of your teeth? Do you think your tooth would last? That stainless steel strip would wick bacteria down under the gum line. It would attract plaque. You would get a chronic inflammatory reaction, and you would eventually lose the tooth. Think that's what happened in the dogs? In the dogs, using non-sterile strips held in by sutures to retain plaque and bacteria, the bone grew through the holes in the metal and reattached back to the tooth. So yes, we need animal research. Animals do not heal the same way as humans. We care about the biology and the physical handling characteristics. We need to know what they are and how they will work in each site. When you look at placing a material in bone, in a bony site, it can do any of a number of things. It can be replaced if it either dissolves or is removed by certain body cells. When you have osteoclastic resorption and formation of bone by what cells? By osteoblasts, then you have remodeling. That is ideal, because when there's a tooth that's undergoing orthodontic forces, what happens to the bone in the direction the tooth is moving? What do we get to the bone? You don't really want to all fail ortho with the head of ortho in the front row. So if I were to move this tooth into the buccal plate, what's going to happen to that buccal plate next to the tooth? It's going to resorb. What if I put on too much force? Hyalinization of the PDL or resorption of the root? So as bone is resorbing on this side, what's happening on this side? Under the tension side, bone deposition. So all of this is important just in basic adaptation to occlusion from a tooth that has too high a filling. Reossification happens with only one kind of graft material. One of the allografts, or a graft material taken from a different human, is called demineralized freeze-dried bone. That's where the bone is harvested from someone who is no longer with us and processed chemically to demineralize it, and then it's sterilized and freeze-dried. So a bone has two components, mineral and organic, and we now have demineralized freeze-dried bone. What is a one-word definition for demineralized freeze-dried bone? What is the organic part of bone called? Collagen. So DFDBA is only collagen, but in the presence of calcium, nanogen, dentogen, maybe a few other calciums, that demineralized freeze-dried bone will become new bone again. And the ideal property of any bone graft is osteoinduction. That is, if we take bone and place it in a non-bone forming part of the body, a graft, put it in a non-bone forming part of the body, it will form bone. There are only really 3 materials out there that do that. Bone morphogenetic protein, calcium sulfate, tricalcium phosphate. Nothing else is osteoinductive. So if you have a patient who's a diabetic, who's a smoker, who's a poor healer, you want to go as close to osteoinductive materials as you can get to give the body the best chance of healing. When we put our graft material in a hole, you've all done fillings? When you do your filling and your instructor comes over to check it, if they take their Explorer and scratch all your filling out, you're going to get a good grade? So when we place a graft material, we need it to stay in place. We want the materials we use to keep their physical shape long enough for the biological processes of bone healing to happen. Physically, some grafts, if they're just particles and don't maintain their shape and don't have a coat, what do you think is going to happen in our patients? They'll get food in there, they'll get bacteria, they'll get saliva. Anything they can do, they will do. Because it's their job as a patient who is not an ideal patient to have plaque, to get caries, to get periodontal disease. Otherwise, they would only be in your chair for you to say, oh my God, your teeth are beautiful. You have no plaque, no caries. I don't have to clean them. Come, let's take a picture so I can show all my other patients. But that doesn't happen. When we have our graft materials, what we want them to do is sometimes be protected by a Band-Aid. That's keeping people from hitting the place that used to have a thumbnail. With that barrier in place, you can't get food, plaque, quicker growing cells. But sometimes that barrier has to be removed. Other times, and you'll see today, that barrier will physically hold its shape and let the bone form up to it and give you the ideal part of the ridge. And what's the last part? What makes your teeth the shape they are? Why do you see some patients that have very long teeth and not just because they're bigger? And why do some have shorter teeth? Because the location of the gingival margin. So if we can use bone graft materials where we can get even more gingiva, then whether or not that area is going to have a pontic or an implant restoration coming through it, we can develop the ideal shape for that tooth. So here's a patient. Once you start investigating further, I, as a periodontist, have to call the restorative dentist if he didn't send me a letter and say, what do you want in this area? We know what she wants. She wants not to be in my chair. She wants quick treatment and be done. What is my goal? Most teeth as healthy as long as I can keep them in her mouth. To get to the diagnosis, I diagnose the patient's needs or wants, the dentist's needs or wants, but I have to diagnose the tooth, the gingiva, and the bone. So what else do I want? In this day and age, I would take a 3D x-ray. I would take a cone beam scan. But back then, I didn't have it. So what else would you want to look at before you make the final diagnosis of that tooth? Radiograph and maybe periodontal charting. See where that abscess is? If you have an abscess around, is this a vital or a non-vital tooth? If you have a facial abscess around a non-vital tooth, it is either fractured or has a perioendo lesion and you have no buccal plate. In this case, what is the gutta percha? Space holding for titanium. What if that's the x-ray? So, let's go back. Patient wants quick treatment. The dentist, what do you think he wants from me as a periodontist? Crown lengthening. So, if I crown lengthen this tooth where there's no attached gingiva, where there's a fractured root and a perioendo failure, Literally the only thing I can do is a distal root resection, crown lengthen this, and deal with a short endofilm. So here's the real question. Would you do this on a drop-dead gorgeous 40-year-old billionaire? Because that's what she is. Would you do that for your mother, sister, brother, friend, or street sweeper who comes in off the street? To me, the answer is no. To me, the only predictable treatment is to take out the root, take out the disease, and give this area a fresh start. Whether she's going to get a 3-unit bridge, a removable bridge, or nothing, depends on one of 3 factors. What are the only limitations to placing a dental implant in a patient? There are only 3 of them. Not enough time, not enough bone, not enough money. I can grow bone really well in a lot of places. And as Sachin saw yesterday, I could magically move bone a little bit too. We cannot make time for the patient, and we can't make the money. We can bend on the price. We can bend on how long they pay us out. We also can't get past some of their emotional factors. There are some patients who would say, take out the infected root, and I want to at least keep part of the tooth. That's a different discussion. So I want long-term predictable results. To me, that only is happening if I take the tooth out. So if we don't add a bone graft and a barrier, and in another lecture we'll go through, especially for the surgically oriented people, we'll really go over the literature. But if you don't graft and or barrier every extraction socket, every bit of literature in humans and animals has shown that you lose bone every time. Every patient, every site. So, if you don't graft and barrier, and money is the issue, it's either because the patient really doesn't have it, or because you haven't conveyed the essence of how important it is to preserve that space for the future. Even if the patient has no desire for an implant, a fixed or removable bridge at this time. I'm going to give you an idea of money in my office. If I have Ellen, and I take that tooth out, and don't graft it, just a plain extraction, $350. If I place a bone graft and a barrier, now we're up to $1,150. If I take the tooth out, or somebody else has and has not grafted it, and I'm coming back to do a ridge augmentation, that's $4,000. And as good as it is, it's not as predictable as if I had been able to place a bone replacement graft at the time of extraction. So it is always necessary for ideal treatment to preserve the bone and preserve the gingiva. So we look at the literature, we look at the science, we look at wound healing to get our results. When you have a patient like this, you can, if there's enough width of bone, place implants. If they have a very low lip line, you use pink porcelain and you're done. In general, the patients who don't have enough bone have the money and want the implants. So you're going to have to either be able to rebuild the hard and soft tissues or put the team together to do it. So our conclusions in the paper were that you should always, if you can, preserve the ridge. Problem is, there's so many different studies out there. You can't compare them all. They use different grafts, different barriers, different socket treatments. But if you preserve the bone at the time of extraction, you will not lose 3 millimeters horizontally. You will not lose 1 millimeter vertically. Think about this. The average premolar is about 7 to 8 millimeters buccolingually. On average, most of the studies show if you extract a tooth and don't graft it, you lose 35 to 50% of the width. So if we're talking about a bony width of 10 millimeters, lose half of that, that's only 5. Premolar, ideally we want to place a 4 millimeter diameter implant with 2 millimeters of bone on the buccal, 2 on the lingual, means we need an 8 millimeter ridge. So if you take out a premolar and don't graft it, then you're violating literature principles based on biology to replace that tooth. Barriers are not always necessary. And you'll see in some of the cases Sachin and I talk about why not. But you need to know the patient, protection of the site, and biomaterials before you can do that. So whenever you can, fill the hole. Here's an analogy. You have a patient who comes in with a cavity. You clean out the decay, have a nice day. Would you ever leave a cavity open? That tooth is not going to mystically reform in the area. So you need to think about what's out there and what you can do, even with the limited resources your patients have, to get the best possible for them. So in the hole that was just filled with a blood clot and a barrier over it, he got full bone in the dog in 3 months. Dogs heal at 3 times the rate of humans. So because of this, they said you should let it go for 9 months. We get this same result in 3 months with either a barrier alone or some of the grafts you'll see later. What about if they put the anorganic bovine bone mineral in? You see the bone mineral embedded in connective tissue. Is connective tissue vascular? Not so much down in there. Do you see any blood vessels? So if you have no vascularity in the area, then you're limiting your ability for a blood clot to form. What we need for an implant to heal in bone, or osseointegration, we need a blood clot that attaches to the implant surface and lets the osteoblasts and osteocytes migrate to it. So the less bone you have, the less ability you have for an implant to integrate. Now let's ask a question. If we're taking an x-ray buccolingually, are you going to see the connective tissue or are you going to see the graft? The graft is radio-opaque. You won't be able to identify bone healing past all this white mass that you see. So in the equivalent of 9 months in a human, and this is borne out in human studies, you have mainly dead graft material embedded in connective tissue. But look what happens with the calcium phosphate. Calcium phosphate is a salt. It dissolves. Calcium sulfate is a salt. It dissolves. We don't need the osteoclast we talked about earlier to get it to dissolve. And when it dissolves, it releases free calcium. So let's look at a couple of grafts. This is one that I actually was part of the original science animal research projects. This is a sintered bovine bone with a growth factor embedded on it. So here's a patient we used it in. That's the graft the day of placement, and that's demineralized freeze-dried bone with calcium sulfate. But if that is to become bone in a normal time when we as surgeons want to place in implants, would you want to see the particles or would you want to see a nice healed bony ridge? How's that for 6 months later? Here the bone didn't fully heal, but it surely looks a lot better than that. In the anterior, it looks even worse. If it looks like your bone graft on x-ray, if it looks like your bone graft clinically, if it looks like your bone graft when you place a hollow drill in to sample the piece, do you think that's living vital bone? Where are we going to get our vascular ingrowth to meet the surface of the implant to get osseointegration? So there should be no surprise that histologically there's a little bit of bone, but mainly graft material and connective tissue. So yes, I hate to tell you, if you go into perio, endo, ortho, oral surgery, you still need to remember your histology. If we look closely, graft material, a little bit of new bone, a lot of connective tissue. So, if this graft material were resorbing, what would we see on the surface of it? Osteoclasts. So does anybody see any osteoclasts eating away the bone? So if it hasn't been found in 6 months and recognized as a foreign body to be eaten and dissolved, it's never going to be dissolved. This is osteoconduction. It's only a scaffold. So Ellen, do I want to put a graft material in that replaces with bone, if I'm going to use a graft? Do I want to do some sort of treatment that I could at least see on x-ray what happens? Sure. This is my end goal, an appropriately shaped crown. Implant supported with keratinized tissue, minimal to no inflammation. So here's what we're starting with. No buccal plate on the distal. Is that a surprise? Fractured root, endo, and an abscess. We knew there'd be none. But now let me ask you a question here. That's the buccal plate on the mesial root. When the tooth was intact, what's the blood supply? 3 areas that supply bone around a tooth with blood. What are they? Come on, some of you still have to have voices. You don't want me to cry, do you? So PDL, yes, is 1. So that would be the blood supply to here. Where would the blood supply to the outside of the bone come from? Periosteum. This, by the way, this section has voices. This group needs coffee or tea. What about inside the bone itself? Where does the blood supply come from? Marrow spaces. So if we go back here, we don't see any blood supply in the connective tissue. So if the graft is embedded in a connective tissue, you wouldn't expect bleeding because it's not mature enough to have its own vascular supply. So let me ask you a question. I needed to open a flap to get full access to debridement to this. So I had to strip a little of the periosteum off. So is there any blood supply to the outside? When I take out the tooth and I curette the PDL, is there any blood supply to the inside? Now, this bone is so thin, it's the cribriform plate on the lingual and the cortical plate on the buccal. No marrow spaces. So, is there any blood supply internally to that? So, question. Have any of you ever had, either yourselves or a patient that had a 3rd molar removed and had a little bone spicule come out? What do we call that bone spicule? A dead piece of bone that's being exfoliated from the body. Sequestrum. This is a sequestrum. It's relative, it's dead only because it's avascular. So does it make sense that if we don't protect this, it's going to disappear? So for Ellen, this is what I want. I want living vital bone. But what do you notice? There's not as much here and there's much less up there. Because what I did is I put, to get living bone, I just put a barrier. I did not place a graft. And that did not let me reestablish the contour here and maintain the contour here. So yes, I got full living bone, and I got connective tissue and keratinized tissue, but look there and look a little bit here. That's not a failure here. Ellen will have that forever. But if it's in the aesthetic zone, on any patient who's going to pull their cheek or lip or has a high smile, that could cause a problem. So there are times we can get away with just a barrier, but understand the limitations. Right here, it's a little deficient. Right here, it's a little deficient. But this is still more than clinically acceptable because I have living vital bone. So let's talk anatomy for a second. Posterior maxilla, vital bone percentage. So if you took a chunk of bone out and analyzed what percentage of that volume is mineralized, 25%. Lower posterior of the jaw, 35%. 40 to 45 in the premaxilla, and 50 to 70 in the anterior mandible. So if we look at Ellen and we look at the whole core, we have almost 70% vital bone. So just by protecting a blood clot, we got more bone than she had before. And you're going to see in a little while how we do that with other graft materials as well. So one of the most popular bone graft materials in the world is anorganic bovine bone mineral. You're going to see lots of lectures on it. On this one patient, I took out 3 premolars. One covered the blood clot with a barrier. What does a blood clot become in a tooth socket if we let it heal? It becomes bone. A blood clot in any bone-surrounded site will become bone. So here, let's call that 20% bone, where we just protected the blood clot. But look what we have over it. Connective tissue where we lost height and width. The graft material alone at 6 months, 4% bone, 21% graft. The graft covered with a barrier at 6 months, 7% bone, 32% graft. Any osteoclasts? That graft is non-resorbable. So, my gold standards. I want what my mother, the philosopher, used to say, if a little is good, more is better. I want more volume of bone. I want more volume of keratinized tissue. Better to withstand food, better to withstand brushing. I want enough height and width that I can place an implant. After the surgery I did yesterday, that changes a little. And to me, which I think one day will be proven in the literature to help prevent and decrease the risk of peri-implant disease, I want as much living, vital, osseointegratable bone as I can get. The more bone I have, living bone, the more internal vascular structure I have. The more of the body's own nutrition and healing components can be added into that site. And I want as little of what I dumped in the hole to be there when I go take my core. How do I know this will work? Because it's not just pretty pictures. I'm not showing you dentogen mixed in with the DFDBA and a dentogen barrier because Sachin said, let's talk about dentogen today. You saw with the calcium sulfate mix, the graft held its shape. With the self-setting barrier, it held its shape and it did not break down. The patient, even as lousy a patient as she is, had full healing and full vital bone based on biology. That's why it works. Not just because I say so, but because I showed you the histology